Thank you so much to our sponsor, Guardant Health. Next up, we will hear from our poster presenters who will be talking about their very interesting projects in cancer prevention and screening. After each presentation has concluded, we will have a short time for Q&A with the presenter. Just like our earlier formats, you can speak using the raised hand feature if you'd like to ask a question, or share a comment or use the Q&A text feature. We will be addressing the raised hands first, and we will try to get to as many questions as possible. And first up, we have Sigrid.
Hello, can you all hear me?
You're a little quiet, but yes, we can hear you.
Oh, okay, let me speak up. Is this better?
Yes.
Thank you. So thank you. It's nice to see all of you, even though it's just a small window on a screen. I hope you're all doing well during these trying times. Thank you to the Prevent Cancer Foundation for this opportunity to present our work that we have done with funding from the foundation. And my talk today has a very long title. It's called Primary Care Physicians' Perceptions of an Electronic Medical Record Embedded Decision Support Tool for Prostate Cancer Screening, a Focus Group Study. So we heard in the previous session, we talked about paradigm shifts and using the electronic medical record to integrate decision support tools to facilitate screening. We also learned that a lot of the times the decision to get screened is often initiated by the physician more so than the patient themselves. So our idea was to build a tool that would be provider facing to help providers have conversations with patients. I have no disclosures pertinent to this talk, and all images are stock photos. And as mentioned, this study was funded by the Prevent Cancer Foundation, and also I am funded by the National Institutes of Health and the NCI. This study was a collaboration between Memorial Sloan Kettering Cancer Center in New York and Brigham and Women's Hospital, Harvard Medical School, and Harvard Business School in Boston. So by way of background, as you know, when used properly, prostate-specific antigen screening can reduce prostate cancer mortality. However, screening remains relatively underused in younger healthy men and overused in the older, less healthy population. And you can see here in this image that the bars are higher to the right in the picture. So older men are more likely to have had a PSA test than younger men or men aged 50 to 54. So we hypothesized that the widespread failure to follow well-accepted PSA screening guidelines is because these guidelines are relatively complex. And as you know, primary care physicians are very busy and they lack the tools to efficiently employ shared decision-making procedures in their practices. So as part of a larger project to develop and implement a decision support tool for PSA screening for primary cares, we conducted a focus group to sit down and chat with the primary care physicians and ask them about their attitudes towards these types of algorithms for PSA testing, their perceptions of using tools like this, and to assess the feasibility of implementing such a tool in clinic. So what we did was that we assembled a multidisciplinary team. We had experts in primary care, urology, behavioral sciences, and bioinformatics. And we developed a version 1 of this tool, and we used the NCCN guidelines, so the National Comprehensive Cancer Network, which is a well-established guideline for PSA screening. We then developed narratives for this decision support tool using principles from behavioral economics that would prompt the doctors to follow the guideline recommended directions. We also used a provider-facing tool for shared decision-making. It's called the Simple Schema, and it's basically 10 simple talking points that the man and the physician can discuss when considering having a PSA test or not. We then presented this tool to the doctors in the focus group, and we had 10 doctors participating from Brigham and Women's Primary Care in Boston. We followed standard procedures, we asked open-ended questions, and we took notes that were audio recorded and transcribed, and then we coded the transcripts to see what themes came out of this analysis. And these were the results. We were fortunate to have a sample that was representative of the demographic distribution in terms of age, gender, ethnicity, and years in practice for the 10 doctors. And we had 3 major themes that came out of the data. The first was very positive. We had confirmatory reactions regarding the importance of the innovation and the unmet need for a decision support tool that would be embedded in their electronic medical record. One participant said, "That's the powers of computer, actually." And someone else said, "Having this guideline makes me feel more comfortable with ordering the initial PSA." The second theme was issues around implementation and application of the tool in their clinic workflow. As you know, they're super busy. And one doctor said, "How many minutes do you have on average for your visits?" Well, -5. So it was important that the tool should be easy to use and not take much time. Another doctor said that doctors might have their own biases that might color the conversation. So here's an example. One said, "My grandfather, my father had prostate cancer, and they both had really awful side effects from treatment. And I tried to get rid of that bias." So by having a tool with some talking points would help to obviate these biases. And the final theme was attitudes and reflections regarding discrepant recommendations from various guideline groups that cause confusion. And you might notice that all the guidelines in the past recent years have been all over the place, and they have been conflicting, and they've been changing back and forth. So no wonder why this is a very difficult topic for doctors and for men also. Physicians also appreciated that the tool would allow formal documentation that shared decision-making has taken place, because as you know, all the guidelines for PSA testing nowadays recommend that it needs to be preceded by a discussion about shared decision-making. Another important feature of the tool was to allow for flexibility and leeway for clinical judgment. So even though the guideline might recommend something, then the clinician's judgment should always be able to override or ignore whatever the tool tells. So for example, if someone has very strong family history, or there might be other reasons why you would screen a younger man, for example. So most clinicians agreed with the ages to start and to stop that the tool would recommend, but described that family history and African American race would push clinicians towards starting screening earlier, which makes perfect sense. There was a 50-50 split between whether or not clinicians also included the digital rectal examination as a primary screening test in conjunction with the blood test PSA. So in conclusion, there was overwhelmingly positive support for the need of a provider-facing decision support tool to assist with PSA screening decisions in primary care. And incorporation of these suggestions from the primary care physicians from the focus group into a version 2 of this tool will be used in a subsequent pilot testing in clinic. And today we have actually finished this pilot test for 6 months in the primary care physicians' clinics. And I am just about to analyze the results from the surveys that we have now received from the doctors. And I just took a quick glance at them, and I was very pleased to see very positive results. Almost all physicians said that the tool was very useful, even though it was slightly burdensome, because it's, you need to get used to a new tool in the system. They found it useful, and they would recommend it to a colleague. And they also found it overall very easy to use. So, so far so good, looks promising, and we will of course continue to test this tool in the future. Thank you.
Thank you. We will now open up for any questions, and taking the raised hands first. We have a question in the Q&A section. Someone asked, what EMR system did you use for this?
Yeah, so we used Epic because that was the system that was used in Boston. That's a very common tool. So we worked with programmers in Epic to implement this.
We have a raised hand from Norma. Go ahead and unmute your microphone so we can hear you speak.
Yes, my question has to do with, I know this is formative research that you were conducting, but did you notice any emerging themes coming from your focus group? For example, the ideas of female physicians and the positive response or negative response from patients as against male physicians, and the response from their patient for prostate cancer screening?
That's a good question, and no, that was not a theme that came up.
Okay, thank you.
Thank you.
Someone asked if you can show your summary slide again of the results.
Okay, let me see if I can go back. This one.
As a reminder, the raised hand feature and the Q&A is available if you have any questions or comments. Someone asked if you can show the slide right before the conclusion slide.
Okay.
We have a sort of common question. You mentioned participants appreciated the documentation of your shared decision. Is this shared decision a requirement for men to get a PSA test through insurance?
No, that's an excellent question. There have been some discussions with the American Urological Association and the CMS, the Center for Medicare Services, because for lung cancer screening, in order to obtain a CAT scan for screening, it needs to be preceded by shared decision making. So that's a sort of requirement. And there have been some conversations about that to happen also for PSA testing, but not that I'm aware of yet that it's a formal requirement. But it would be, nice to be able to formally document this in the electronic medical record going forward.
We have time for one more question. A question was asked, are you able to discuss the questions that walk the provider through the shared decision?
Yes, certainly. We can go back. I don't know if the slides will be available after this, but there's a link here, if you can see, to the paper. So this tool was published in the Annals of Internal Medicine by Dr. Vickers and colleagues. So if you click on this link, that will take you to the full text of the paper, and that has this tool. So feel free to use it if you like it. It's like I said, it's a simple schema, so it's very simple, the 10 talking points, and it condenses the key facts of prostate cancer screening, the key take-home messages, and then facilitates the making a choice. So it's a tool that some men have found, and doctors have found, very useful.
Thank you so much for your presentation and your time.
Thank you.
Next up, we have Ileana.
Hi, everyone. Can you hear me, Jasmine?
Yes, we can.
Great. Well, hello, everyone, and thank you so much for joining us today. And I hope you are all doing well during these unprecedented times. I also want to thank the Foundation for having me as well. I am a postdoctoral research fellow at the Georgetown Lombardi Comprehensive Cancer Center, and today I'll be sharing a little bit more about some very preliminary analyses that we conducted to understand interest, awareness, and use of Juul, a specific type of e-cigarette, among young adults. Sorry. Okay, let's see. I'm just trying to... There we go. Sorry about that. Okay, so although we know that e-cigarettes may be beneficial to adult smokers who completely switch to a less harmful tobacco product, we do know that the public health benefit of e-cigarettes is unknown and uncertain because e-cigarettes are not harmless and they pose risks of health harm and addiction, particularly that they are associated with subsequent use of combustible tobacco products, which is the leading cause of cancer. And so of particular concern is the high prevalence of use among young adults during a critical developmental period where we know that nicotine addiction, such as use patterns and use behavior, as well as poly-tobacco use, can increase and escalate. And so the one thing about e-cigarettes that is really concerning is that the class of electronic cigarettes is very versatile and it is constantly evolving. So that means that there are countless types of brands that are available on the market, as well as countless types of e-cigarettes, including those that are disposable Mod Pods, those that are rechargeable, those that are like modular systems, or those that are tanks and can be refilled with liquids. And so that makes it really challenging to address e-cigarette use, particularly among young adults who are exposed to vast tobacco marketing for these products. However, one particular brand does stand out as it has grown in popularity tremendously among US young adults. And so about 75% of the US e-cigarette market share has been taken over by Juul. And so this is particularly concerning because they use appealing marketing, as well as they have sleek design and modern features and high nicotine content that appeals to young adults. And so this is particularly concerning as 11% of young adults have tried Juul and 7.7% are also current users. And a lot of this use is driven by misperceptions about Juul, particularly as it relates to risk perceptions of health harm and addiction. And what we do see is that Juul, in comparison to older generations of electronic cigarettes, do contain nicotine salts, which are known to be more addictive than free-base nicotine formulations of older generations. Unfortunately, there is limited evidence to date on how to effectively communicate the risk communication messaging of Juul and similar electronic cigarette products. And so as a very initial step, we did conduct an online study to understand a little bit more about Juul interest and use among young adults. And so 332 young adults between the ages of 18 and 30 were recruited online using Mechanical Turk in June 2018. And the self-reported survey included measures of demographics, which included age, gender, race, household income, and education, as well as cigarette smoking status, which involved 2 valid questions that examined overall lifetime use of cigarette smoking, which includes, having smoked greater than 100 cigarettes in your lifetime, as well as being a everyday smoker or a someday smoker. And the single item that measured Juul awareness and use was, let me make sure I have it. So the single item was stated as, before today, have you ever heard of or used Juul vapor products? And in terms of the available responses, we collapsed them so that the 3 categories were never heard of the product, heard of the product, and never used it, which would be categorized as aware, as well as having used the product. And so in order to understand the associations between sociodemographic characteristics as well as cigarette smoking status, with awareness and use of Juul, we used bivariate associations, including chi-square tests. And so to briefly summarize the sample of young adults in this online study, the mean age was 26 years old, and the majority were male, white, had household income less than 50,000, and there was a variability in terms of education, and the cigarette smoking status was mostly smokers. And there was also variability among having awareness and use of Juul vapor products, with 48% having never heard of Juul in terms of the time period of June 2018. And about 31.2% were aware but never used Juul, and 16.8% had used Juul recently. And in terms of the results, so when we look at the associations of the demographic characteristics with Juul awareness and use, we do see that there are significant results in terms of having never heard of Juul. So among white participants, white young adults, 56% had never heard of Juul, while 36% of non-white young adults had never heard of Juul. But what is really interesting is, although the awareness is about relatively the same in terms of proportion, the number of non-white young adults who have used Juul was higher than those among white adults. In terms of education, we do see variability again among those who had never heard of the product, but what is really interesting is among those who are aware of Juul but had never used it, we see higher proportions among those with less than high school education, college students, and college graduates. However, when it comes to the proportion of those who had used Juul, we do see that the proportion is higher among college students, which means that this population might be of particular interest when it comes to addressing risk factors or targeting a particular priority population among young adults. In terms of cigarette smoking status, we do see across the board that non-smokers overall are less likely to have heard of Juul. And in terms of awareness and use, we do see a higher proportion among smokers in terms of having used e-cigarette products. And this could be for numerous of reasons, such as working towards quitting smoking or just being more likely to use other types of tobacco products and poly use altogether. In terms of next steps and directions, so these preliminary analyses were really helpful because it actually is leading into my postdoctoral fellowship award that I received from Prevent Cancer Foundation, where we're really hoping to use these preliminary results to expand, to understand more granular associations. And so the overall focus of the postdoctoral fellowship is a multi-phase study where I'm going to develop and test the efficacy of risk communication messaging targeting Juul as well as other similar other similar e-cigarette products. And so these are my 3 specific aims, but the preliminary analyses that I just shared is really feeding into the observational study. And I do apologize about some of the font here that didn't fit into the screen, but we are hoping to first examine young adults' reasons for Juul interest in use, their risk perceptions, again, more on a granular level. So understanding what types of health harm or types of diseases do young adults really understand when it comes to e-cigarette use, as well as their use intentions and motivation to quit among current users. And so we were actually hoping to have launched this part of the study already, but with the COVID-19 and the pandemic and understanding use of tobacco products, I felt like it was best to kind of hold off for the moment. And so we're hoping to soon launch this observational study to kind of get the ball rolling, but we are very excited about it. And I think that's everything that I have. Thank you very much.
Thank you for your presentation. We will now take time for Q&A. You can ask questions via the Q&A box or raised hands. Okay, we have a question from the Q&A box. Is there any information about the use or decline in use of e-cigarettes since the last severe respiratory issues that occurred last year?
That is a great question. And so we, unfortunately, right now, we don't have more information on that, but it is something, you know, in terms of developing this observational study, it's actually pretty timely where we're able to include questions. I know the respiratory issue was a little bit earlier, but in the same breath, kind of with the same understanding of, okay, like how do we include questions about COVID-19 and understanding associations with e-cigarette use for that product. And there was a lot of misinformation too with the respiratory issues that we saw earlier on with e-cigarette use. And so part of the communication and messaging that has kind of come out through that is to really correct those misperceptions and making sure people have the right information.
We have a raised hand from Erica. Please unmute your mic so I can hear you speak.
Yes, do you mind showing your results again, just for me to kind of look at that again, please?
Was there one particular result that you were interested in, Erica?
No, I just kind of wanted to just overlook it again. That's all. Thank you.
As we're waiting to move backwards in the slides, one thing that is interesting is so that these results were analyzed and examined as a part of a different online study. And so what I'm really hoping to do as the observational study of the PCF-funded project is to really start to understand, you know, the granular levels. So for instance, with race, we only were able to look at white individuals versus non-white individuals. For the observational study, we're actually going to oversample minorities. So then that way we can be able to really look at, you know, which subgroups would benefit the most from risk communication messaging so that we can prevent e-cigarette use among susceptible non-users and to also reduce use among current users.
We have a raised hand from Jodian. Please unmute your microphone so we can hear you speak.
Hi, thank you. Since I'm a high school teacher, is there any possibility of this study being published, or has it been published? in any type of journal like the Journal of School Health?
That's a great question. Thank you very much for also suggesting a journal that might be a good fit for this project. We currently, I haven't been able to conduct the observational study, and this part was very just, I would say, more of informative research. But I am excited and looking forward to being able to have the observational study and publish those results. Among young adults and youth in particular, what is really important, I think, is understanding the kind of the dynamic landscape of e-cigarette products. And so one thing that I'm considering right now is how with, Juul is I would say still popular, but other types of products are also emerging, such as Mod Pods that are disposable. And so as we're thinking about, how to move forward with results as it relates to benefiting youth and young adults, it would be interesting and important, which is something that we're trying to do, is to really understand patterns of use of the different types of e-cigarettes as well as the different types of brands. But I'm looking forward to publishing these results as soon as we have them.
Thank you for everyone's questions, and thank you so much for your presentation and your time. Up next, we have Allison with her presentation. Allison, we are unable to hear you.
Jasmine, are you able to hear me now?
Yes.
Okay, sorry about that. I'm already having some technical glitches, but I'm Allison Antoine, and I am here to talk to you about the use of the Peer Learning Collaborative as a tool for quality improvement in our colorectal cancer screening program. And that's me again there. And I did just want to acknowledge that I'm obviously the one here presenting today, but I had a much larger team that I worked with, and that we didn't have any disclosures to report. And that also our project was funded by the Centers for Disease Control and Prevention. And so to provide a little bit of background, first, our colorectal cancer control program in Wisconsin was funded in 2015 as a part of CDC's National Colorectal Cancer Control Program. And at the time that we were funded, about 75% of our state, age 50 to 75, were considered up to date with their colorectal cancer screening, compared to about 34% of our state's FQHC patients. And the federally qualified health center partners that we had identified through this project primarily served a large population of underserved patients in our state, which made up of kind of our target population of those average risk adults aged 50 to 75 who were due or overdue for their colorectal cancer screening. And so myself, along with the other program staff that I've worked with over the last 5 years, we have been partnering with 9 federally qualified health center health systems in Wisconsin to address colorectal cancer screening through the strategic implementation of evidence-based interventions, which we abbreviate as EBIs, as well as using a lot of the data that gets generated from the EBI implementation to lead to data-informed decision-making, with the idea that that would lead to some continuous quality improvement efforts, as well as this component of utilizing face-to-face peer learning collaborative sessions to bring together these partners who are working on a very similar project in their individual health center, but kind of create that shared space for them to come together. And I realize talking about face-to-face meetings in our current environment of COVID-19 does present some challenges. And so we are kind of looking at how we can maybe adapt some of this work moving forward given our current environment. So the overall goals of this project was to increase colorectal cancer screening rates. At the time when we were funded, the national goal put forth by the National Colorectal Cancer Roundtable was 80% by 2018, which has been further adapted to be 80% in every community, as well as to decrease disparities in colorectal cancer screening, and as well as incidence and mortality of the disease for the patients who are served by our partner health centers. And the strategic implementation of these evidence-based interventions was critical to the creation of a high-quality colorectal cancer screening program within each of our partner health centers. And a lot of this work was really focused on making sure that appropriate screenings and recommendations were happening, patients were adhering to those recommendations in a timely manner, and that follow-up kind of processes were in place, including getting patients in for diagnostic colonoscopies following an abnormal stool test. And specifically, one of the activities that was a major component of our work over the last 5 years was this peer learning collaborative, which we held sessions twice a year. Again, they were in person. Our partners were spread across our state, so we would kind of choose a different location each time to bring our partners together. These sessions were facilitated by our program staff, and it really created a dedicated time for our partners to come together and share their successes. Equally important to sharing successes is sharing what isn't working. You know, we titled those exemplary failures, as well as challenges and lessons learned, and maybe even less of a focus on best practices and more of a focus on promising practices, or kind of what is looking to be helpful. And so during these peer learning collaborative sessions, again, it was a consistent opportunity for our partners to come together, and it created a space for us as the program staff to also share program level information, because although we were very focused on the work that was happening within each health center, this also was part of a larger statewide program. The peer learning collaborative sessions also created the perfect opportunity to introduce external content experts, as well as specific topics that we wanted to share with all of our partners, including some opportunities for professional development. One of the biggest kind of takeaways from the collaboratives was that the opportunity to crowdsource ideas. So it was a space where you could come with your problem or your challenge, and you could kind of throw it out to the group, and we kind of were able to have those brainstorming sessions, as well as the opportunity to showcase those achievements made and the successes, as well as those exemplary failures. And the image on the screen here is a screenshot of an exemplary failure certificate that we had given out at one point in time, which we've seen several of those hanging on the wall of some of our partners' offices, and they're fun to see. So some of the consistent components that were built into each of the sessions over our project period was the idea of creating space to do team building. Each of our partner health systems had kind of a core colorectal cancer team, and we found pretty quickly that many of those team members don't naturally work together in their kind of home office, so creating that space was really important. Again, the sharing of exemplary failures along with those successes was also incorporated into each session. And then we also put a large emphasis on how to use data and how to use it effectively in order to drive their work forward, and really use it as a tool in this idea of using continuous quality improvement practices for something like colorectal cancer screening. And some of the external content experts, as well as specific topics that we brought in, kind of cover a wide range of topics. And we really chose these speakers and these topics based on feedback that we were getting from our 9 federally qualified health center partners. And so some of the topics included sustainability planning, which we were very fortunate to work with the Center for Public Health Systems Science at Washington University to administer their program sustainability assessment tool, or the PSAT, to kind of lead us through some sustainability planning and coaching. Quality improvement coaching was also very important, as this is a quality improvement project at the heart. And so we worked with our local quality improvement shop, which is called Metastar, to do some kind of basic QI coaching. As well as we kind of tried to think outside of the box sometimes, and this idea of how to be influential when you don't necessarily have authority to be influential came up throughout our work. And so we were able to bring in a career coach from Wisconsin to kind of coach us through how to really lean into that growth mindset to build influence when you may not be, the CEO of your organization. We also were able to work with George Washington University to do some kind of disparities workshops around cancer screening. And I think one of the topics that was the most, it was most enjoyed by the largest number was our Lean for Healthcare workshops that we were able to offer to our partners, which really focused on waste elimination. And waste is just, not necessarily the waste you normally think of, but when you are in a health center, kind of all the extra work that you're doing that really isn't leading to the outcome you're hoping for, as well as some basic lean principles. So we were able to hold 8 peer learning collaborative sessions across our 5 years of funding. And this project coincidentally wraps up here on June 29th. And after each session, we had our participants complete an evaluation, and we always had very high evaluation completion results because in order to get their parking pass, to get them out of the parking structure, they had to turn it in for their evaluation. But we always asked our participants kind of, what actions are you going to leave this session with? And you can kind of see the list up there. But I think some of the most exciting ones that we saw and were able to kind of track and see, did these things happen, was related to, getting a provider champion. This work needs a champion. It's going to just kind of die on the vine without somebody really leading it. Creating an onboarding process for new colorectal cancer team members, promoting the project within my organization, things like that. These are very tangible things that we were able to capture from our participants and kind of see whether or not they ended up happening later on. So this slide just has some pretty quick little graphics here that does show that our average participant overall rating was pretty high. We were pretty proud of these scores. Also, our average participant level of agreement with the statement, I have learned from others successes and challenges in implementing EBI. So 4.5 out of 5 was really great to see, because I will say trying to get a multidisciplinary team from 9 different health centers across our state in one room twice a year is a challenge. And so it was one of those things where we'd get a little bit of pushback when we would release the date for the next collaborative, but by the time it rolled around, people were always happy to be there, and we got really good feedback on our evaluation. And so since we were funded in 2015, our colorectal cancer control program, which we locally call Screen for Life Wisconsin, has achieved a weighted screening rate increase of about 18%. And this is really a result of the fact that this program is a comprehensive multi-component program, which includes the opportunity for consistent in-person peer learning collaborative sessions where our partners are able to come together. They're able to, like I mentioned, crowdsource ideas and really kind of bounce ideas off of each other. And it really helped, I think, our partners with the sense that this work is really hard, and they weren't alone in it. And there were oftentimes peer health centers or peers that were working on something very similar, and they might have a different way of thinking about it.
As a reminder, we have 2 minutes left for your presentation and Q&A.
Sure. So I guess I will just kind of wrap it up there and just emphasize the fact that providing this opportunity has been really beneficial. We realize with COVID, we will now need to reimagine how this might work. And I'm happy to take any questions. And I'll skip forward and share my email address too, in case anyone wants to get in touch via email.
We have a raised hand from Norma. Please unmute your microphone so we can hear you speak.
Yeah, I'm not playing devil's advocate here, but I wondered if your IRB balked at the idea that the completion of the evaluation was contingent on receiving the parking pass.
No, that is a good question. And when we submitted this at the very outset of our work, we were exempt because it's a quality improvement project.
Ah, gotcha.
We have a question in the Q&A asking if you have a link to the sustainability tool that you mentioned.
Yes, I can put a link to the Washington University's organization. They created the tool. I guess I can put it in the Q&A or the chat, Jasmine, maybe?
You can type in the chat.
Okay, I'll put it there after I'm done.
That's all the time we have for questions. Thank you so much for your presentation.
Thank you.
And next we have Ann Kelly.
Jasmine, can you hear me?
Yes, Ann Kelly and Heather Quinn. I apologize.
Yeah, it's okay. It's all right. I'm Heather Quinn, and I'm here with Kelly, obviously, to share with you some findings. We were with the Kentucky Department of Insurance, and we are market conduct examiners. So we regulate and examine the conduct of specifically health insurance companies. And recently we've completed an exercise which has uncovered some barriers to preventive cancer screening due to coding and billing of claims. Jasmine, I'm having some trouble advancing. There we go. I'm sorry.
Who would like control?
Heather. Thank you. So I want to also acknowledge Patrick Smith and Shasta Pack, who are also examiners with the department and were essential in this examination. So to give you some background, the Affordable Care Act requires that preventive care services be covered without application of cost sharing by insurers. In 2016, CMS awarded a grant to the department to examine the application of this requirement by the 5 major carriers in Kentucky. The parameters established by the law and various guidelines were utilized as guidelines for compliance unless Kentucky mandated benefits were more stringent. In those instances, Kentucky law was applied. While various federal agencies put forth recommendations on what constitutes preventive care, there is no one source of definitive coding for preventive health care insurance claims. And so pardon me. My mouse is more sensitive than I thought.
You can also use your arrows to advance or go back in your slide.
Thank you. My rehearsals were not this sensitive with the mouse. I apologize. So our goals and objectives were first and foremost to evaluate compliance with the preventive health care coverage requirements of the ACA. And then, as in most exams, to also track what was preventing compliance and monitor areas of non-compliance to assist the companies to getting into compliance. And then thirdly, to educate consumers, providers, and insurers on preventive benefits and the potential billing and coding issues. Our methodology was pretty standard. We used standard market conduct examination processes for sampling and reviewing the data collected from the insurers. We then framed the recommendations into ways that we thought would be able to organize the data, sampled the data, and then kept in mind the variance potential between if the recommendation does not specify the frequency, method, treatment, or setting for the provision of the service, because that would result in the carrier using medical management techniques to determine any coverage limitations, which is allowed. However, it creates a coverage variance by carrier because there's not a clear connection between the guidance and the codes used for claim billing purposes. There was also an issue in the diversity of implementation between carriers. One carrier may go beyond the recommended guidelines and cover a screening for anyone and deem it preventive, while others strictly adhere to recommendations including gender, age, health history, state laws related to prevention. For example, in Kentucky, we have laws that are more stringent related to preventive care screenings than the federal law. And with that, I will pass it to Kelly.
Hello, I'm Kelly, and I wanted to get just a little bit more on the granular level of how we started this. So we all know cost is a barrier to preventive care, and one of the mandates of the Affordable Care Act was for insurers to cover preventive care to 100%. They also defined preventive care, and the definition included guidelines and recommendations from United States Preventive Service Task Force, Bright Future, Health Resources and Service Administration. So, but none of those recommendations included a billing code level, which made it very challenging for insurers to be able to input that into their claim system. Just wanted to also note that our data is all preventive services, not just preventive screening, cancer screening. So anything that was, our data will be on all preventive. The recommendations that when you look at this, you have to look at claims logic or how the insurer billing system adjudicates claims. And so basically the provider sends in a claim and has an ICD and a CPT code. So the CPT code is the service code. So when we got all the claims data from all insurers, we had to decide what preventive codes were going to be utilized. So since there's no guidance on that, each carrier kind of had their own CPT codes and ICD-9 codes that they used. So this graph is kind of shows you how diverse and complicated it could be for a provider's office. For example, there's 671 unique CPT codes for preventive services, with the insurer's knowledge. Of those, 152, all 5 insurers covered. 217 of them, only one carrier covered that service. So it was not just one carrier, but one carrier specifically to those 217. So as you can see, all 5 carriers was 152, 4 carriers was 126, so on. So, and when you look at that, that's a 25% chance that all carriers were going to be coding that. the next step is to add in your ICD-10 codes, which it dramatically increases the numbers. So one carrier, when you look at the combination of the two codes, one carrier had 1,500 codes and the other one had 43,000 combinations. The total combinations for all codes for all insurers was over 110,000. And when you look at that in a kind of the same way I looked at the CPT codes, if you look at that, one carrier only, or one carrier would only have 93% of coding combinations that were unique to a single insurer, while 21 out of 110,000, or less than 0.02%, were shared consistently and paid as preventive for all insurances. So now you can see the difficulty that what providers have when they're billing these codes to know what exactly to code. The other complication is the providers always don't really know this, because providers bill a service, they get paid. It comes to what are the cost sharing the member has. So the provider wouldn't necessarily see this problem, they're going to get the money, but the insured would see the problem because they would get billed for that service. Sometimes you notice it, it's a $20 vaccination, you might not notice that. But if it's your colonoscopy and you got a $6,000 bill, you had to meet your copay or deductible, it's more noticeable at that point. When you look at the financial impact, all the cost shares together, and there were some insurers that were better than others. However, when you take it as an average, 52% of the amount paid by Kentucky patients during the exam period were, they paid stuff that they shouldn't have had to pay. And when we looked at that, it was over $800,000 in claims, which is a lot of claims when you look at $20 copays, but then you add in the $4,000 for a colonoscopy. So which I think is a great disparity toward people, because once you tell me something's free, and then I get a $4,000 bill, I'm less likely to believe you next time you tell me something doesn't have a cost share. Which also gets into the fact of, when you have preventive health care, you have a premium of your insurance. That's figured into your premium. If it's free, you really already paid for it. So you paid for it in your premium. So I encourage, that's another reason to encourage people to utilize it, because they've already paid for it necessarily in their premium. In the next slide, you can see, I was going to try to bring it to cancer. So on the next slide, we have cervical cancer screening, which all know that's one of the best ways to prevent cervical cancer. Pap smears. The preventive code for Pap smears alone, one company used one code, so it was a specific CPT code, only one. Another company used 15. Next slide, Heather. And so one for one company, 15 for the other. In comparison, colorectal screening had a more drastic change. One company used one code, company used 259. To add to the confusion, next slide. To add to the confusion, there is, you have to consider place of service, age, gender, risk factors, specific state mandates. All that adds into the complexity of the code logic that they have to put in their system to know what to pay for. For example, we had a complaint at the department that their tobacco cessation counseling wasn't getting paid. When we reviewed it, person appealed it at the insurer. They said, "Oh, we paid it correctly." But when you look, the error was in how they input or what they put in their claim system, and they didn't use a place of service. The service was the hospital. So as we all know, if you got admitted to the hospital for COPD and you needed some smoking cessation counseling, you would have that done in the hospital. But no one had ever thought that through. The place of treatment should not be a consideration, but the guidance on how to fulfill these recommendations was silent on that. We also had another case where a pap smear, the doctor's office had coded it routine exam. That specific code had not been put in the system to be able to code that way. Therefore, if the patient hadn't known to complain and appeal, they would have never got that paid. So really what the main focus that we came to with this is amount and volume of CPT codes that can be used varies so dramatically that we recommend getting a standardized code. Heather.
This is just a notification that you have about 2 minutes left in your presentation and for Q&A.
Okay, Heather. Speaker's off, Heather.
Thank you. Thanks, Jasmine. We'll just make this brief and say, like Kelly just said, we feel that in order to provide appropriate preventive care as required under the ACA, that a formalized form of guidance for providers and insurers to use to bill effectively will then enhance consumers' ability to go out and gather those services, therefore reducing healthcare costs and hoping to provide conditions like cancer from being diagnosed at their absolute worst and more early intervention occurring. And I'm going to put our emails in the chat in case anybody wants to email us questions, since we had a little technical difficulty there. Thanks so much for your time.
Thank you all.
It looks like we have a raised hand from Teresa. Please unmute your microphone so you can speak. Teresa, it looks like you're unmuted. Please ask your question. We have a raised hand from Jodian. Please unmute your microphone so we can hear you speak.
Yes, I would like to ask a quick question. How do the doctors get the codes that they need to use if it's sort of federal regulated?
Well, they don't get the codes. They get the guidance on the provision, and then they and the insurer both have to make the determination what code aligns to that, that diagnosis and service. And so that's where the challenge comes in, is that, like Kelly said earlier, there could be one very specific code that says, for cervical cancer screening, this is the code, this is the type of person, it's a female, it's a certain age range, this, and this. And that insurer might lock that code down to be the one that's for cervical cancer screening, but another insurer may not put any gender limitations on it, any place of service. And so the challenge is that the insurers have all had to develop guidance to tell providers that how to code their claims to get paid appropriately, but they aren't all consistent. So everybody's set up their system and everybody's trying to do the right thing, but it's a challenge for the two parties to come together because there's no overall guidance. I think it's the AMA that puts out the CPT and ICD code books and provides those guidelines, but they don't say which codes align to the guidance that's provided by Bright Horizons and USPSTF and others.
And one other thing, that providers have portals to each insurance company, and those portals have claims, things that they can put in and know. The problem is if you're at a doctor's office, and it's not only, you would have to go in to each carrier to know each single one for every single circumstance, and it gets really burdensome for the office or the hospital. So that's what makes it hard. That's why we're recommending that if everybody can agree and have the same codes, then that can solve this issue. The problem is when you look at an insurance carrier having 1,500 codes and another having 43,000, it makes agreeing a little bit difficult. So if AMA or CMS or someone could come out with the specific codes to cover, that would be highly beneficial for this process to get done.
Yeah.
It's just a bigger picture than what we had originally thought.
Thank you so much for your presentations. That's all we have time for Q&A.
I'll answer the questions in the Q&A, the typed in questions in the Q&A. So people, if you have a question out there, I'll make sure to put an answer in there for you.
Perfect. We appreciate that. Next up, we have Danite.
Hi, can you see me?
Yes, we can.
Okay, great. Hi, everyone. My name is Danite Yamane, and I'm the Hepatitis B Project Coordinator for the African Services Committee, which is a multi-service agency based in Harlem, New York, dedicated to assisting immigrants, refugees, and asylees from across the African diaspora. We provide health, housing, legal, educational, and social services to roughly 10,000 people each year. And today I'd like to present on my team's work for Project Deliver, which is on decreasing and eliminating liver cancer by increasing viral hepatitis testing and educational resources in New York City. Next slide, please. So before I begin, this is just a brief outline of what I'll be discussing. First, I'll start with the goals and objectives for this project. Then I'll explain some background information on viral hepatitis, the methods that we used for this work, along with the results, limitations, conclusion, and next steps for the future. Next slide, please. So in terms of our goals for this project, we wanted to use viral hepatitis B and C education alongside early screenings, which we provided at off-site testing events that we hosted and at our office in Harlem, as well as vaccinations to increase liver cancer prevention and awareness among vulnerable African immigrant populations in New York City. Next slide, please. To provide some context, primary liver cancer is a leading cause of cancer deaths worldwide, and chronic hepatitis B and C infections can lead to liver cancer, and they are responsible for roughly 80% of hepatocellular cancers. So in terms of the population for this work, we chose to target African immigrant communities in particular because viral hepatitis is endemic to about 8 to 20% of the African continent as defined by the CDC. So with that said, African immigrant communities are at great risk for viral hepatitis infection, and they're often unaware of their status, lack health insurance coverage to get tested, and also suffer from language barriers and cultural differences with health practitioners in the US. For these reasons, we found it especially important to focus our efforts on the African immigrant communities in New York because they're vulnerable and lack the critical support and education that's needed to combat viral hepatitis. So in terms of our methods, my team and I carried out this work by hosting community awareness and screening events throughout New York. The events allowed participants to receive hepatitis B and C education and screenings for free. We provided educational resources like pamphlets and palm cards and various materials to participants as we talked to them about the importance of getting tested and knowing their status. To promote our events to the community, we also conducted outreach to African-born community members using radio ads on African stations, posting about our events on social media like Instagram, Facebook, and Twitter, and collaborating with community leaders and faith-based organizations serving the community. We developed promotional materials, which we gave out for free at the events, and these were also used to increase engagement and decrease stigma regarding testing. And upon arriving at each location for our testing events, it was also really beneficial that my team is also primarily composed of African immigrants ourselves. So because we reflected the target population that we were hoping to connect with, we found that it was especially helpful in just establishing trust and being able to provide culturally competent education on viral hepatitis and even the native languages of most of the participants that we worked with. So several of the community members that we spoke to, we provided this education in French or in Wolof or various African languages. And again, this greatly increased the trust that we established between the community members, and it empowered more people to participate in the screenings. Next slide, please. So our results were as followed. Between August 1st, 2019 and January 1st, 2020, We hosted a total of 8 community events with 97 hepatitis B and C tests that were conducted. 21 total participants tested positive for hepatitis B, 10 at the offsite events, and 11 at the African Services Committee office. And all the positive participants were linked to care through an African Services Committee staff member. 10 total participants received the hepatitis B vaccine at African Services Committee, with more scheduled to return for vaccination. And 0 total participants tested positive for hepatitis C RNA. So looking back and reflecting on some areas for improvement, most of our offsite testing events were hosted in Manhattan and the Bronx, mainly due to convenience for African Service Committee staff members. The vast majority of us live in either one of those boroughs, so it was more convenient for us to work and commute to each of those locations to provide testing events. And they also only mainly occurred at religious places of worship, so we hosted several events at mosques and churches. But to broaden our target audience to non-religious community members and also the remainder of New York City, we will need to find other places to screen individuals, like community centers, schools, or potentially places of employment, and in other boroughs as well, so Brooklyn, Queens, and Staten Island. Another limitation is that the majority of the participants who we screened were men, so increasing our outreach and screening for women in particular would be extremely important for future events. And then lastly, we also encountered some cultural and language barriers, mainly for participants who were recent arrivals in the US and did not speak English or languages common to our staff. So to better accommodate those participants in the future, we can improve our cultural competency by having more diverse staff who hold the skills beneficial to target that population for future outreach efforts. And lastly, just to briefly summarize what I've discussed, we learned that, community-based outreach and education methods were extremely powerful tools in engaging the African immigrant populations in cancer prevention awareness. Our events raised awareness regarding liver cancer risks and prevention and helped break down stigma, mainly by speaking in the same language and having people who, again, shared some sort of cultural tie with the participants we were hoping to connect with. And so with that said, we believe that culturally competent education, screening, and navigation remain very powerful and essential early prevention tools to protecting underserved African immigrant populations from liver cancer. And looking forward, we hope to improve our work in the future by addressing the limitations I mentioned earlier after the COVID-19 pandemic, of course, but when we do resume hosting events, we want to increase our outreach and screening in Brooklyn, Queens, and Staten Island and attempt to target more community organizations and places of employment as opposed to just religious places of worship. We will definitely increase the skills and competencies among our staff, so having people that speak far more than just French or Wolof or other smaller African languages so that we can reach a broader range of people. We also will place an emphasis on increasing our outreach and screening for women in particular, and establish community partnerships and ties for each place where we hold an event so that we can come back for future programming. Next slide, please. So this work wouldn't have been possible without the generous support of the Prevent Cancer Foundation, and for that we want to say thank you, as well as the collaboration and partnerships between African immigrant community leaders who helped us plan and coordinate the testing and educational events themselves. So along with the help of also our partners of the African Services Committee, we're really indebted to several folks for all of the support that they've provided us with. And I'd also like to just give a quick thank you to my team, who is extremely supportive and always willing to help me, as I recently joined African Services Committee in November. And they really helped me get onboarded on this project very quickly, and were extremely supportive. So thank you to them. And that's it. So if there are any questions or comments, I'm happy to answer any of them.
Looks like we have a raised hand from Norma. Please unmute your microphone so we can hear you.
Oh, wait a minute. Am I unmuted?
Yes.
Okay, great. I was wondering, considering the language limitations and other cultural barriers, did you find that it was necessary to develop relationships with this population before you were ready to ask questions related to your research? And if yes, how did you go about that?
Yes, I definitely think it was very helpful to have a relationship established prior. For some of the places that we decided to host events, we had either a staff member who, for instance, may have frequented the mosque or church themselves, sort of speak to whoever the religious person or leader was, to essentially give us the okay to come and be able to speak about providing testing and educational sources. I think that if you don't have some sort of partnership or some sort of liaison between yourself and the community, then it makes it far more difficult to attempt to get people to want to get tested. It just seems like, again, people enjoy seeing a familiar face or seeing someone who can establish some sense of familiarity between us and the community that we're attempting to provide testing for. So if you don't speak the local language and you don't have like a direct connection, then yeah, we noticed we weren't very successful in just trying to do outreach, for instance, like on the streets of Harlem, with pamphlets and paperwork saying that we provide free testing, please come check us out. That wasn't as effective as having someone who is already established in a particular place speak on our behalf and explain to people why it's important to get tested and why they should trust us and why they should want to work with us.
Thank you.
Mm-hmm.
All right, we have time for one more question. Erica, please unmute your microphone so we can hear you.
Hi, this is Erica Bailey. I'm in Staten Island, New York. Your target group is the African community, is that right?
Yes.
Okay. I am in Staten Island in regards to outreach activities as we reopen and life gets back to a new normal. I'm happy to connect with you.
That'd be awesome. We have heard that there's a pretty big Liberian population in Staten Island, so I actually have been trying to find someone who could put us in contact with potential places to host events, anywhere that we could really reach, a pretty broad population of people. So I would definitely love to connect with you after this.
Great. If you could share your email, that would be great.
Sure. I can. I don't have access to the presentation from here, but I could potentially get your contact information from anyone here. If you can put it maybe in the question and answer box, or I can put my email there. That works.
Thank you.
No problem. Thank you.
All right, thank you so much, everyone, for your questions and for your presentation.
Thank you.
Next, we have Mary Ellen for her presentation.
Hi. Good afternoon. Thank you for having me talk with you all today. My name is Mary Ellen Kahn, and I am a Assistant Director of Cancer Prevention and Control at the WVU Cancer Institute of West Virginia University. And I also serve as the Program Director for our state's colorectal program, the West Virginia Program to Increase Colorectal Cancer Screening. Just to give you a little bit of background in regards to colorectal cancer in West Virginia, it is one of our most significant cancer problems in the state, with high incidence and mortality. And the most recent data that we have from our state's cancer registry show that just a little over half of all the diagnosed cases really came in as either being regional stage or distant stage. So we see there really is a need for improved early detection. And West Virginia, we are a rural state. We are totally encompassed within the Appalachian region. So there are some specific cultural, social, and educational barriers that impact a lot of our patients' willingness to be screened. So the West Virginia Program to Increase Colorectal Cancer Screening, we are one of the CDC-funded colorectal cancer control program grantees. We partner with health systems around the state to implement evidence-based interventions to increase their colorectal screening rates. And our goal is to help them increase to the national goal of 80% or at the very least 10% over their baseline. And I'm going to talk today about a client reminder intervention that we have done with many of our health system partners. We refer to this as an enhanced call reminder program because it's really looking at bringing in a little bit of theory of the constructs of stages of change in order to be able to conduct some tailored reminder messages through calls to achieve a greater return rate of fecal immunochemical tests. So for in clinics where a patient was given a FIT but it doesn't get returned, this is an enhanced reminder intervention that they had done. And I'm going to be reporting on data from 9 health systems that represented 18 clinics. These health systems had anywhere between 1 and 5 clinics that participated in our program. And the data was collected over a 10 to 17 month period. We actually did this intervention and data collection. We had 2 different cohorts. So cohort year 1 are in blue. These were counties that were prioritized to work in. They had high rates of colorectal cancer mortality. They were considered a colorectal cancer hotspot. And our cohort year 2 clinics, the priority was given to clinics that were in counties that have high rates of late-stage diagnosis. So our implementation strategies for doing this is we worked with each clinic to design the workflow protocol for the distribution of the FIT and then the actual follow-up and the reminder process. And our ideal was for the reminders to be initiated around 7 to 10 days after the patient took home a FIT, but it didn't come back into the clinic. But we did actually, work with each individual clinic, kind of really looking at what their current workflow and capacities were. So those workflows did vary. So for many of them, the reminder process started at 1 week, and some it didn't initiate until 2 weeks, and we actually had one that they didn't initiate the reminders until about 3 weeks out. Each clinic identified a staff person or persons who would make up to 3 reminder calls for the unreturned FITs. We trained the staff on stages of change, the use of an algorithm to help them to determine what stage of change a patient may be in, as well as the tailored messaging for each of those stages. And we had them utilize a tracking log to monitor the reminder calls as well as to aid in data collection. And a secondary component is that we collected cost data. So we were really looking at the average staff salary and the amount of time that staff were spending to track unreturned FITs and how much it took for them to make the calls, as well as also send some patient reminder letters. And this is just an example of one of the workflows for one of our clinical partners. This is actually a workflow of a clinic that they started their reminder process 1 week after the patient took the FIT that did not come back into the office. And we based this around stages of change. We felt it was important because with this, it's really looking at the decision-making process that's involved in making some form of intentional behavior change. And it's a framework that can help to assess an individual's readiness to transition, to complete that behavior, as well as providing some strategies to help move them towards what the intended behavior is. And studies have shown that moving one stage increases behavior change by 30 to 50%. So, and looking at what the stages of changes are, we really looked at trying to create some tailored messaging specific for these. And in our project, we really focused on just the first four stages because this was a short-term project. There was a short amount of turnaround time. So we knew that most patients wouldn't have enough time to actually have their tests completed and returned in order to be considered more in maintenance. So for some patients, they kind of fall into the pre-contemplation stage. These are the ones that they really don't see themselves at risk. And so the communication strategy for these folks is that we want to try to personalize the risk. And so messaging given to these patients would be things such as, anyone can get colon cancer, but risk is higher if you're age 50 and older, and you need to be tested even if you feel healthy. The contemplation stage, these are the folks that they're thinking, this is something I need to do. And so the strategy for the contemplation is, oftentimes finding out, do they have some perceived barriers? And then trying to minimize the perception of whatever barrier they might potentially have. So some messaging that can be used for these folks is, tell me what do you think is going to be difficult about completing the fit. Preparation, these are the folks that they're actually ready to do the test and get it ready to bring back into the clinic. So the strategy for this is that you really want to try to reinforce the intended behavior. So for those patients, the type of messaging would be really, I'm glad to hear that you're going to take the test. Do you have any questions about how to complete it? More or less really trying to reinforce them to do that. And then for action, these are the ones that they they've just completed it. They're getting ready to bring it back into the clinic. And so the strategy for them is you really want to show, highlight they've taken an important step for their health and reinforcing that behavior and make them aware of the expectation that for FIT there is the need to be rescreened within a year. So we used an algorithm to train the staff, and we focused it on stages 1 through 4. And basically just, they would ask, when they would call, they would ask the patient, did you complete the screening test that was given to you by your provider? If no, then it was asking them, when do you plan to take it? And then based on their response, it would indicate what stage they were in, and then the appropriate messaging would be given. So what was the outcome on this? Overall, there were over 5,000 FITs that were ordered, and the average rate of initial return, these are the FIT tests that came back in on their own without any reminder, was 41.1%. And you can see that the range of that initial return was from a low of 16.1 all the way up to a high of 70.7. And in a moment, I'm going to talk about these two particular differences in the initial return and what the difference in the workflow was for these two particular health systems. So for the test that did not come back in, where a reminder actually needed to be initiated and given, after reminders, the average return for any outstanding FITs was 41.2%. So we saw an overall return rate of 60.7, and this was achieving an average increase of 19.6 percentage points. And we feel that this increase is fairly significant because when looking at the studies that were reviewed by the U.S. Preventive Services Task Force in the Guide to Community Preventive Services, when looking at some of those studies of reminders for fecal tests, those studies were showing an average return of 11.5%, and all but one of the health systems that did this intervention had return rates that were higher than 11.5%. So this is showing just by each of the health system, where their initial rate of return was, what their return rate was after reminders were given, and then their total return rate. So if you really look at health systems 2 and health systems 3, you can see the vast difference in their initial return rates. And the reason why we saw such a difference with those, health system 2, their workflow varied in that it didn't start until 3 weeks after a test did not get returned. And the other difference in their workflow is that theirs started out with mailing a reminder letter first, and then a certain number of time would elapse if the patient did not return the test after that letter, then reminder calls would be placed. And then in health system number 3, this was actually, they had a total of 4 clinics that participated, and what the difference was in this one is that patients would talk with the provider, they would be offered the FIT, they would have to stop by the laboratory before they checked out in order to pick up the test, and the lab technicians were taking some extra time to really talk with the patient and educate them about the test and explain to them and make sure that they understood what they needed to do to complete the test. So really taking that little bit of extra time in the clinic resulted in a much higher return rate. We also looked at doing some cost analysis. So we looked at the average total cost of the tracking, the amount of time it took for doing the calls and the mailings. And so the average total cost was $60.18. And you can see that, so that ranged from a low of $8.99 to a high of $352. The average cost of reminders only, just the cost of them to implement a call or a letter, was $11.20 per fit returned. We did have some limitations with our cost analysis. For one, it was retrospective data collection on that. We also had 2 health systems that had significantly higher cost for tracking, and that was due to one of them was having issues with their electronic health record. So staff were having to spend a lot of time actually going into the EHR, searching for patient reports in order to be able to follow up and see who needed to get the returns. And then at another site, they were having difficulty getting lab completion reports, so a lot of time spent calling the lab in order to find out what the results of that were. And then as many of our clinics, they were rural clinics that have smaller patient populations, they're generally going to have higher costs due to low volume and economy of scale. And then this is just kind of showing the difference for each of the health systems where their costs were. You can see here for health system number 3 that had the really high rate of initial return. They had the lowest cost because they weren't having to do as much of the reminder process. And then health system 4 and 5, these were the outliers that I just talked about in terms of having very significantly higher cost due to some problems.
Just as an update, we have about 3 minutes left for the rest of your presentation and Q&A.
Okay. So we saw that the timing of the initiation of the reminder impacts. The earlier it's done, the better. The initial mode of the contact really does make a difference. So the tailored message phone call worked better than sending a reminder letter. So having that personal touch really did make an impact. We also saw that the average total cost per fit returned was in similar range to another study that was done in community health centers. Reminder calls could really be made by a variety of staff. These were being done by nurses, health coaches, care coordinators. In some clinics, it was actually being done by front desk staff, as well as we saw that the extra staff time to educate patients about the test while they were in the clinic did have a higher return rate with less need to do the reminder. As far as challenges to do this intervention, updating the clinic workflow to integrate the reminder protocol. In some clinics, they had concern about duplication of tracking, doing it on the spreadsheet log versus in their EHR. We also had some inconsistent tracking and data collection. We had an additional 7 clinics that actually did the intervention, but we had to exclude them from the data analysis due to inconsistent reporting. The clinics that actually did this for a longer period of time, staff turnover and need for retraining, as well as despite efforts to remind and reach out to patients, unfortunately there are some that they just do not complete their screening. And I just want to give acknowledgement to our health system partners, the members of my team that worked on this project, as well as our external collaborators. So thank you very much.
Thank you for your presentation. We have time for 1 or 2 questions, and it looks like we have a raised hand. Norma, please unmute your microphone so we can hear you speak.
Yes, I was wondering, in your discussion with your potential participants about the stages of change, were you able to discuss with them the possibility of relapse and, you know, that it's not necessarily that they've failed, but it's a setback and that they could, you know, get back on the wagon and be a success?
We actually did not get focused on that particular issue, being the fact that this was very short term. And that we were only following them over a certain amount of a short amount of time, generally within a 3 to 4 week period is how much the total follow-up time was.
Okay.
But that's a very good point that you made about stages of change.
Okay, we have time for one more question. If there are no more questions, this concludes the end of our conference. Thank you so much for everyone and your questions and your presentations. If your hand was up and you didn't get your question answered live, click on the Q&A button at the bottom of your screen. Please type your question, including to whom it's addressed. One way or another, we will try to get your question answered. Thank you again for joining our 2020 Prevent Cancer Dialogue Part 2. Please join us for Part 3 on Wednesday, July 1st.